procedures. Local and systemic side effects are common in patients under treatment with BCG, which is the most common medication or treatment used nowadays. And about half of the patients fail to this treatment. Some of these patients will require radical procedures with diversion or chemotherapy and radiation. And the muscular invasive has also a very high or portends a green prognosis, and about only 50% of patients that will undergo radical cystectomy will survive 5 years. Having said this, it is a real honor to have today with us one of the gentlemen, the colleagues and friends who had a lot of experience on the topic of bladder cancer not only Philadelphia, but worldwide, as is done Dr. Leonard Gomela. Lenny is Bernard Godwin Professor of Urology and Chairman of the Department of Urology at Kimmel Cancer Center Network in Philadelphia, and Senior Director of Clinical Affairs at Jefferson Kimmel Center. He is a member of many of the most distinguished societies, and is past president of the American Association of Genitourinary Surgeons, and he's been also elected as a member of the prestigious Clinically Genitourinary Surgeons. The University of Kentucky, which is his alma mater, also awarded him as a distinguished alumnus in 2009. And he has been also the president of the Society of Urologic Oncology, same as the Mid-Atlantic section of the American Urological Association. I feel really honored and pleased to introduce Dr. Gomela, who will speak to us in the next minutes about his experience and what's going on and what in this field and non-muscular invasive bladder cancer. Lenny, the table is yours.
Super. Let me make sure I have the proper screen sharing here. Do you see that first slide?
Yeah. Yes, sir.
Yes.
Very good. Well, thank you, Angel, for this wonderful opportunity. I'd certainly like to be there in person, but we know the world is very different right now. So I appreciate this opportunity to be with you remotely. Let me see here. Did that change?
Yes, sir.
Okay. So Dr. Alvarado did a very nice job of looking at the GloboCan data on bladder cancer. I've looked at it a little bit differently, so it's going to be reinforcing what he said and what I said. If on this particular listing, bladder cancer globally was in the top 10 cancer, again, more common in males than in females, as we all know. But here's something I did a little deeper dive on, and that was looking at bladder cancer around the world. And Dr. Alvarado noticed that in Central America and Latin America, that bladder cancer will be increasing in the coming years. But at least at the present time, from a global standpoint, it looks like Central American countries are at the lower end of being burdened with bladder cancer. So again, Dr. Alvarado gave a very nice overview of bladder cancer. Tonight, we're going to be talking about these elements, and that is the carcinoma in situ, pathologic TA, and pathologic T1. Our goal is to prevent the development of muscle invasive and more advanced bladder cancer. Urothelial carcinoma in the United States, we have about 80,000 cases a year. And as the GloboCan data suggested, Fortunately, the majority are superficial, meaning that our ability to preserve the bladder safely and rid the patient of the cancer is quite good. So this is just a general overview, and we're going to do a deeper dive on a lot of these areas, but we're talking about non-muscle invasive bladder cancer. And the initial management, as we all know, is all visible disease is resected. We'll talk a little bit about enhanced cystoscopy using blue light SISU at the end of the talk. If patient is T1, they undergo a repeat TUR. If they have a high-grade lesion, the standard of care is BCG intravesical therapy. And if low-grade, normally follow-up cystoscopy is all that is indicated. As Angel pointed out, BCG immunotherapy is the standard of care and in general is superior to intravesical chemotherapy, although we're going to see a little bit later that perhaps combining chemotherapy together may give us a good alternative to the current worldwide shortage of BCG. So where we are right now with BCG failures, valrubicin is really the only one officially approved by the United States FDA. The best salvage option is still considered to be radical cystectomy. However, we do have some other interesting agents. Pembrolizumab from Merck was just approved for the management of BCG failures. We also have a whole bunch of investigational drugs that we will talk about are out there. And while they're investigational per se, they can be used off protocol since they are FDA approved for other indications. So BCG intravesical therapy for non-muscle invasive cancer is probably the best known immuno-oncology agent in the world. And it was actually originally approved in the United States in 1990 for non-muscle invasive bladder cancer. It's clearly an immune modulator and the mechanisms we'll talk a little bit about, because the mechanisms of BCG are actually being looked at and being capitalized upon by the development of some of our newer agents that we have in non-muscle invasive bladder cancer. And while it is a safe drug, Dr. Alvarado did note that some patients can develop some serious complications from the drug. So BCG really is considered one of the gold standard medications for high-risk non-muscle invasive bladder cancer. What is fascinating to me is that the different BCG substrains that are used around the world right now are all derived from the same historic course. So here you see the genealogy of BCG going back to the original 1908, 1921 strains of Mycobacterium bovis. And if you look and you travel through the years, BCG Moreau, BCG Tokyo, BCG Sweden, BCG Theiss, BCG Connaught, BCG Pasteur, BCG Galaxo, all are developed from the original Mycobacterium bovis strain in 1908. Right now, the most interest of the alternative strain is the Tokyo strain, which is currently under clinical trial that we'll talk about a little bit later. But I found this fascinating that all the BCG can be tracked back over 120 years. So how does BCG work? BCG clearly stimulates the immune system. The BCG attaches to the bladder tumor. And again, bladder tumors do not have a gag layer. The glycosaminoglycan layer is not present on the surface of bladder cancer. So it preferentially attaches to tumor cells. It is internalized, it is digested, it presents antigen, and then recruits immune cells and leads to a whole series of cytokine production. Most of the activity of BCG can be monitored through the production of intravesical interferon gamma. And lastly, it recruits a whole series of other cells, NK cells, CD8 lymphocytes to induce tumor cytotoxicity. So we all know this is our gospel in our business, that BCG improves outcomes of both papillary and carcinoma in situ. And again, As we've all noted, it is the gold standard for non-muscle invasive bladder cancer in the world. But we've recognized several things. And one of the things that we've come to recognize is that there are BCG failures. Now, here's a series of FDA accepted definitions of BCG failure when BCG doesn't work. These are important because these have been agreed to by the FDA and have allowed other intravesical agents and systemic agents that we will be talking about in a few minutes to be approved by the FDA. So some BCG failure definitions: BCG relapsing bladder cancer is a recurrence after 6 months of being disease-free. BCG intolerant are patients who just can't tolerate the side effect profile of BCG. BCG refractory disease is failure to achieve disease-free survival after 6 months after initial BCG therapy or on maintenance. And BCG resistant disease is disease that improves but then resolves after 6 months and can be evident at 3 months. These are somewhat technical definitions, but have allowed the FDA now to bring forward other medications that are suitable replacements for BCG when it fails or when patients are intolerant of BCG. So at the present time, and the AUA is currently in the process any day now of updating the guidelines in a joint statement by the AUA and the SUO. But at the present time, when you look at BCG relapse and salvage recommendations, if you have immediate or a high-risk disease with persistent CIS after an induction course of BCG, you should use a second course of BCG. If a patient is fit for surgery and has high-grade T1 disease after a single course of induction BCG, the guidelines support the initial discussion of radical cystectomy. Most of us, however, will look for alternative approaches to save the patient's bladder if it's at all possible and if it could be potentially done safely. If a patient is unfit for cystectomy, strongly consider clinical trial enrollment or the use of intravesical chemotherapy. Chemoradiation right now is a low priority in the AUA guidelines, but is getting some increasing interest through some of the newer chemotherapy agents that are being brought forward. The AUA guidelines recommend no additional BCG if a patient is intolerant or has documented recurrence of high-grade non-muscle invasive bladder cancer or CIS within 6 months of 2 induction courses of BCG. So those are the salvage recommendations. However, if we look over here at non-muscle invasive bladder cancer, we can see that the recurrence rate is anywhere from 15 to 61%, and the 5-year recurrence rate is anywhere from 31 to 78%. So the progression rate at 1 year is 17%, and 5 years is up to 45%. So we recognize that BCG is the gold standard, but we also recognize that not every patient does benefit from BCG treatment. So one of the challenges that we have now with BCG is that, well, limited availability worldwide. Several years ago, Sanofi stopped producing the Pasteur strain of BCG, leaving under the name of either Therasis or Immunotherapy, and they removed the production facilities. So what has happened is other novel therapies have really been expanded, and in particular, the SWOG 1602 study is looking very intently at the next generation of BCG, known as the Tokyo strain of BCG. So briefly, what is to be done for this BCG shortage? The BCG can control the cancer in many patients, certainly not all. It can impact progression in many patients, but obviously there's a big concern due to the nationwide shortage of BCG. A lot has to do with the expense and the difficulty of producing BCG, and many manufacturers have gotten out of the business. As you saw, Sanofi was probably the biggest one of the biggest producers in the world. And when they stopped manufacturing several years ago, we ended up with a worldwide BCG shortage. But I want to point out it was not the first time this happened, that Merck was able to speed up their production after 2016. But after a series of problems with expanding their facilities, they actually had to shut down some of their production facilities and bring them up to modern standards. And they claim that the Merck BCG types production will be suitable for the world by the end of next year when their production facilities are fully operational. But again, we'll have to wait for that to happen. So what do we do with this BCG shortage? Well, we've really come to the point that we stress the fact that if you've got low risk disease, there's no reason to use BCG. If you've got intermediate risk non-muscle invasive bladder cancer, consider intravesical chemotherapy as first line, such as mitomycin, gemcitabine, or docetaxel instead of BCG. As a second line, use another alternative intravesical chemotherapy. However, we do strongly feel at the SUO and the AUA that if you have high-grade disease, you really need to take whatever available BCG that you have and prioritize it to those patients who are at the highest risk of recurrence or progression. And those are certainly the high-grade T1 and the carcinoma in situ patients. So if you have enough BCG, certainly go ahead, treat them with the full dose 6-week induction course followed by maintenance. However, as we have done in the United States for probably close to 2 years now, we try to use a half dose of BCG for the induction. The fascinating thing about this reduced dose of BCG, we actually don't know the optimum dose of BCG. Because of the way BCG was manufactured and distributed for intravesical use, we just use the standard whole vial. But actually what we're finding is maybe we don't need to use the whole vial. And certainly we reassure our patients that a half a vial of BCG may actually be adequate for them. And it allows us to double the number of patients that need to be treated with the induction course. For maintenance therapy, if the supply exists, we use 1/3 dose of BCG. And what we have recommended by the SUO guidelines and the AUA guidelines is that limit the maintenance therapy to 1 year. Unless you have a good supply of BCG, maintenance doses should be limited to 1 year. Using this right now, we have actually not seen big problems with more advanced disease. So as I mentioned earlier, perhaps reducing the dose of BCG allows us to maintain its high therapeutic index. And again, using alternative chemotherapy, including mitomycin or other agents, is acceptable. And in patients with high-risk features, really try to give them BCG, but also consider these patients initially for radical cystectomy as a potentially life-changing approach. Although we'll see here in a couple of minutes, we've had such wonderful advances the last 2 or 3 years in intravesical agents, including new ways to look at chemotherapy. Maybe radical cystectomy may not be as urgent a recommendation as we thought before. So what are some of these novel options beyond BCG in terms of either BCG shortage or BCG refractory disease? On average, up to about 40% of patients may not respond, or over a 5-year period may become refractory. And again, cystectomy is often recommended for these high-risk patients. At the present time in the United States, really, valrubicin is approved only for carcinoma in situ in patients who are unfit for radical cystectomy. We actually do have an approval for thiotepa in the United States for bladder cancer. However, I could tell you that it's a few and far between patient who has been treated with thiotepa. And one of the problems with the thiotepa can be myelosuppression that can be quite severe. So you almost never see Thiotepa used, although it does have a label indication for bladder cancer. One of the biggest strategy right now is off-label chemotherapy. And we're not talking systemic chemotherapy, we're discussing intravesical chemotherapy. And we'll talk about actually some of the more exciting discoveries that we've had with intravesical chemotherapy over the last 1 to 2 years. There's no question that with the legacy of BCG being one of the most impressive immunomodulators in all of cancer, many immuno-oncology-based treatments are under investigation. And actually, as we'll see in a few minutes, one of them, pembrolizumab, systemically administered, the PD-1, PD-L1 inhibitor, was actually approved in January of this year. Other novel delivery systems are being looked at, electromotive strategies for mitomycin C, other combinations of agents are being looked at. But in the next couple of minutes, what I really want to focus on are the currently available or the near-term agents that you may have available to you for BCG refractory or BCG intolerant patients. So compared to BCG, chemotherapy using a monotherapeutic agent, and I want to stress that, most intravesical chemotherapy that we have done to date has been monotherapy. Paclitaxel, docetaxel, doxorubicin, epirubicin, Thiotepa, and many other agents have been given intravesically, but none compared with the response of BCG. Again, as I mentioned, while Thiotepa is approved, really the only intravesical chemotherapy that we have available right now in the United States is valrubicin for carcinoma in situ in patients who are unable or unfit to undergo radical cystectomy. But very commonly used off-label are gemcitabine monotherapy and mitomycin C intravesical therapy. So we talked a little bit about some of the modern chemotherapy trials that are ongoing. We talked about the thermochemotherapy, which is being used extensively in Europe, looking at electromotive strategies to get better penetration of mitomycin into the bladder wall. Gemcitabine is under study as a very interesting intravesical system. It's sort of a little pretzel that you put in the bladder. And when you put it in, it folds up to a pretzel. It goes in straight and then assumes a configuration and leaks out gemcitabine over a prolonged period of time. Mitomycin C in gel, Mitagel. Everyone knows about the approval in upper tract disease recently for urothelial carcinoma, low-grade refractory in the upper urinary tract. That Mitagel is also being studied in the gel form of mitomycin C in the bladder. But again, that is a research study that is ongoing worldwide right now. So combination chemotherapy has now been reported for BCG refractory non-muscle invasive bladder cancer. And actually, this was reported just at the AUA virtual meeting the end of June this year. And this is intravesical chemotherapy that was combination. It had gemcitabine combined with docetaxel, and they were each instilled in the bladder with dwell times of about an hour and a half sequentially, and this was done for 6 weeks. Some of the patients received some oral bicarbonate. Some of them received oral nausea medication, since some of the patients did get nauseated with the intravesical installation. But while this was not a retrospective, a prospective trial, the data was retrospectively analyzed in several hundred patients at multiple centers. And I think you could see most of these patients on paper should have had a radical cystectomy. And this is quite impressive data. The recurrence-free survival is 60% at 1 year and 46% at 2 years. A very, very low progression rate to muscle invasive bladder cancer was reported. And I believe this is either in press or about ready to come out in the Journal of Urology. But remember, this is combination intravesical chemotherapy. This is just not intravesical monotherapy. This represents, though, a very wonderful alternative to our BCG shortage. So urothelial carcinoma immunotherapy. We know that BCG works in the bladder because it stimulates the immune system. And the other issue is that bladder cancer tends to have a very high rate of mutations, meaning that the body is able to recognize it as not being there. Tumors that have a very low mutational rate can sort of fly under the radar screen, and our body's immune system is not able to recognize them. However, certain cancers, lung cancer, bladder cancer, melanoma, have so many somatic mutations that it's fairly easy for the body's immune system to recognize them. We also know that urothelial cancers actually express compounds that suppress the immune system, such as PD-L1. We know that CD4 and CD8 T cells express compounds that are inhibitory to prevent the overstimulation of the immune response. And we'll talk a little bit more about this, but we have to remember that if we're not careful, we can stimulate an autoimmune disease in a patient where the patients, by using our drug therapies, we can take the brakes off the immune system so far that our own innate immune system begins to reject our own normal tissues. So this is a very delicate balancing point at the immune checkpoint. So the checkpoint inhibitors that we keep hearing about enhance the anti-tumor effect by allow a more robust immune response. But again, we have to be careful that this immune response is controlled. So here you see a graph that looks at mutations in a variety of tumors. And again, the number of mutations, the frequency in megabases. Over to the right here, you can see tumors such as melanoma, lung cancer, and bladder cancer have extraordinarily high rates of somatic mutations, meaning that they are excellent targets for using immunotherapy. We also know that the immune system is really a very important regulator of how our body responds to bladder cancer. This particular graph shows a survival in muscle invasive bladder cancer based on the T cell density. So if you look at the T cell density, those patients who have a relatively low T cell density in their tumor have a fairly rapid demise, whereas those patients who have a higher density of T cells tend to live longer. Again, adding more value or clinical data that the immune system in bladder cancer is important. So a basic principle of cancer immunotherapy is the immune system. And basically, it's very important to understand we have things that activate our immune system and things that inhibit our immune system. And it's important to recognize the fact that the inhibitory immune checkpoint proteins, CTL4, PD1, and PD-L1, limit the immune response. These are naturally occurring compounds. However, in tumors and in immune cells invading tumors, very often these inhibitory immune checkpoints are activated at a high level, meaning that as our body tries to reject the tumor, these inhibitory immune checkpoint proteins basically stop the immune system from responding and rejecting the tumor. So what happens is ultimately when these PD-1 and these PD-L1 immune checkpoint proteins are activated, they inhibit the T cell immune response, and essentially this allows tumors to hide from the immune system. So here is a very nice take-home graphic of the immune checkpoint inhibitors. So normally there is a modulation of the T cell response. You can see here the T cell receptor, the PD-1 on the on the T cell and the PD-L1 on the tumor cell interact with each other. And what the tumor cell does with the PD-L1, it tries to turn off the T cell response. So what do we do? By using immune checkpoint inhibitors, PD-1 or PD-L1, what we actually do is we put these antibodies in to prevent the tumor cell from turning off the T cell immune response. And this is the basis of checkpoint inhibitors. Checkpoint inhibitors are antibodies that block the immune checkpoint to enhance T cell and other functions. And in urology, we have several of them approved for advanced disease. We're not going to talk about advanced disease, but we have to understand that this is now being moved into non-muscle invasive bladder cancer. These are some of the FDA-approved inhibitors that we see in urology. They're kidney approvals, metastatic bladder cancer approvals, and now what we also have is the latest pembrolizumab for non-muscle invasive bladder cancer, which is BCG refractory. So these PD-L1 and PD-1 inhibitors are approved in a variety of urologic conditions, including conditions such as kidney cancer. So the first checkpoint inhibitor, Immunotherapy, was approved 9 years ago, and it was, ipilimumab for the treatment of melanoma. Since then, there's been 8 different checkpoint inhibitors to treat a dozen different types of cancer, including kidney and bladder cancer. So let's focus now on non-muscle invasive bladder cancer. I think it's very important to give you guys the background on how we came to use pembrolizumab for the treatment of non-muscle invasive bladder cancer. Remember, there are intravesical trials going on. This is now a systemically administered first-in-class drug for non-muscle invasive bladder cancer. So the traditional dosing for Pembro was 200 milligrams every 3 weeks. There's been some changes in the dosing, but this was the original Keynote 57 trial that looked at patients who had bad bladder cancer, non-muscle invasive, that didn't respond to BCG. They were treated with pembrolizumab, and lo and behold, the complete response rate at 3 months was an amazing 40%. And in that 3-month period, none of the patients progressed to T2 disease. The follow-up was short, but the response rate, the complete response rate, was quite impressive, and this led to the FDA approval. So the duration of patients who did respond at 3 months, over half of them continued to have a complete response duration of greater than 9 months. Again, very impressive in the setting of BCG refractory disease. And again, as I mentioned, in January of this year, the United States FDA approved pembrolizumab for BCG unresponsive, high-risk non-muscle invasive bladder cancer. Again, systemically administered Pembro. So we have a whole bunch of other trials going on right now. There are systemic trials combining PD-1 and PD-L1 inhibitors with BCG. They are looking at other PD-1 and PD-L1 inhibitors, combining them with radiation, and others looking at IV infusion. So again, very hot area, but I hope I've given you the background as to why these medicines are being proven to be so effective in bladder cancer. So this is just one example of a PD-1 inhibitor, Adteladrin, which is being studied by SWOG in BCG non-refractory, BCG refractory non-muscle invasive bladder cancer. These are not the only immunotherapies out there. As we've stressed over and over again, bladder cancer is one of the most immune responsive tumors that we have in all of medicine. And we have a whole series of other medications that have been either looked at or are continuing to being looked at. Many of these are viral based. And again, one of them, which is very exciting, as I mentioned several times, is the SWOG 1602 trial, which is looking at the BCG strain and primarily seeking approval of the Tokyo strain here in the United States. Other things include the mycobacterial cell wall nucleic acid complex. Interferon alpha 2b has been used in the past. Many of you are familiar with it as a monotherapy. It may have some activity in CIS, but it doesn't appear to be durable. It was shown to be less effective than mitomycin or BCG. It did have some responses in some patients, and traditionally, interferon alpha was combined with BCG. And while it did improve some response rates overall long-term in patients who were BCG naive, it didn't necessarily help them. However, there is renewed interest in using interferon alpha in the bladder. One of the concerns about using interferon alpha was that it didn't hang around long enough to do any damage to the tumor cells. So using interferon alpha in cell cultures or in animal models was very effective, but just putting one dose of interferon in the bladder, it didn't seem to hang around long enough to do a effect on the existing tumor. SWOG 1602, again, is the PRIME trial, which is comparing intravesical TICE BCG with intravesical Tokyo BCG. And the fascinating component is revisiting this concept that we abandoned long ago of intradermal BCG and seeing if that helps increase the response rate. So fascinating study, kind of going back to the future, looking at percutaneous inoculation for bladder cancer. So this is something that I'm very excited about. I was involved with these clinical trials through the SUO. It is a modern take on interferon alpha for BCG refractory bladder cancer. The product was originally Adteladrin. The latest product is now called Adteladrin. This is currently at the FDA being considered for approval. And basically what it is, it takes interferon alpha, combines it with a adenoviral vector that allows ongoing production of alpha interferon in the bladder, so you get a sustained immune response. So as we had mentioned before, interferon alpha does have anti-tumor effects. And again, monotherapy with interferon alpha was good, but it was felt that the exposure was not long enough. So what has now been developed is a adenoviral interferon vector that allows the virus to produce interferon in a prolonged period of time. So what we term is the bladder becomes a bioreactor to induce endogenous production of interferon alpha and hopefully increase the efficacy. So here's just a little graphic for the Adteladrin, which again, now the new brand name is Adteladrin. You take the common cold virus, adenoviral vector, adenovirus type 5, you deactivate it, you put in an interferon alpha 2b gene, you put it in the bladder. What happens is it gets taken up by the tumor cells and the cell begins to replicate the viral vector and in turn produces the alpha interferon 2b protein. And again, eventually the virus breaks down and it moves to the next cell. So here's another graphic. Normally you put intron in the bladder and within a day or two it's gone. However, now when you put it in with this recombinant adenoviral vector, you get this bioreactor. So for actually several, at least for 7 days and possibly as long as 10 to 14 days, you continue to get the production of interferon alpha. This SYN3 that it is included with it is actually just an excipient that improves the penetration of the recombinant adenoviral vector into the tumor cells. So SYN3 just is sort of a soap that is included with the product that kind of washes the GAG layer, allowing the tumor, if there's any GAG left on the tumor, to insert itself into the bladder. So the phase 2 trial was run by the SUO and our group known as the CTC, which is the Clinical Trials Consortium. And this original phase 2 trial was published about 3 years ago now. And it showed that in this increasing dosing, that the highest dose of vaccinia plaque-forming units per mil gave you the best long-term response in high-grade bladder cancer. We now have entered a phase 3 trial, and this phase 3 trial has been recently reported. And this was a large trial that looked at patients with BCG, unresponsive non-muscle invasive bladder cancer. These patients had to have failed at least 2 courses of BCG, and the primary endpoint was a 12 months recurrence-free survival. But I want to point out, a biopsy was mandated. A lot of intravesical therapies just allow cytology and visualization. This was a very rigid endpoint where you had to demonstrate no evidence of cancer in the bladder. This was almost 200 patients that were screened, with about 160 being randomized, and they had carcinoma in situ with or without papillary disease in about 70%. So here's a quick summary. The phase 2 trial showed a 35% 1-year recurrence-free survival. The phase 3 trial mandated a biopsy at the end. And what I can show you here is data that was just presented at the AUA and at the GU ASCO, showing that the 53% of the complete recurrence rates were with carcinoma in situ, and all recurred in the first 3 months. Without a mandatory biopsy, it would have been a 25% for carcinoma in situ. However, using the mandatory biopsy, it really showed the fact that you can get a good response long-term with this agent, and the side effect profile was quite good. So to wrap up here, for non-muscle invasive bladder cancer, immunotherapy, high mutational burden means that we have a good tumor to target for immuno-oncology. BCG is the standard. There is limited utility if they're BCG refractory, but combining agents, combining chemotherapy agents may be an improvement that we're going to see in these agents. Many new intravesical agents are out there. We now have checkpoint inhibitors, are a new and novel approach. We think that perhaps the Adteladrin may be the next approved intravesical immunotherapy agent. And again, we have many PD-1 and PD-L1 immuno-oncology trials ongoing. So that finishes sort of my, my formal talk on non-muscle invasive bladder cancer. Dr. Alvarado asked me to just make a couple of comments about 2 areas. One of them is the area of trimodal therapy for muscle invasive bladder cancer. And then we're just going to talk very briefly about blue light enhanced cystoscopy. So first, just to talk about trimodal bladder cancer therapy, and everybody knows that's a combination of aggressive surgical resection, the use of chemosensitizing agents systemically, and then various courses of external beam radiation therapy with the goal to control the cancer and preserve the bladder. What is most important for trimodal bladder cancer therapy is the coordination of the team. Trimodal therapy works best in centers of excellence. It's probably not a good idea to be treated at a center that's not using trimodal therapy frequently. You really want to have excellent coordination between the urologist, the radiation oncologist, and the medical oncologist. The chemosensitivity sensitizing agents that are used are platinum, paclitaxel, 5-FU, mitomycin C, and low-dose gemcitabine. All of these have been used as chemosensitizers, and all appear to have utility, although most of the data right now revolves around cisplatin and 5-FU. Picking the right patient for bladder preservation with muscle invasive disease is very important. The best cancers are those with low volume, those that do not have hydronephrosis, and those that do not have extensive carcinoma in situ. So in centers of excellence, outcomes when it comes to cancer control are actually equal to radical cystectomy at 5 years. And there appears to be an improved quality of life in these patients who are able to preserve their bladder. So Dr. Estefanu from Boston presented this graphic at the ASCO GU meeting last year, and the bladder preservation protocol using Trimodal therapy, you do a maximum TURBT, and then there are different approaches depending on what you do at your center. There's some that use a single course of radiation therapy, others that use a split course. In my experience here in the United States, we don't have a lot of experience with this at our cancer center, but we tend to use the split course of radiation. And the reason for that is that the best way to do a bladder preservation protocol is to do a cystoscopic rebiopsy about a third or halfway through the treatment. If the patient's not responding, they are strongly recommended to undergo a radical cystectomy. However, if they're having a good complete response, they then complete their radiation therapy and then undergo follow-up surveillance for their complete response. If you do the single course radiation, really what happens is that you sort of put all your eggs in one basket right away. And when you rebiopsy the patient, if God forbid they have residual disease, you're then operating on someone who's had a fairly high dose of pelvic radiation. You can see this is basically full dose radiation up to 65 gray. This patient over here, if they have a partial response, have only received about 40 gray, so you don't have as much damage to the pelvis. So we tend to do this at our center. Again, we don't do a lot of bladder preservation, but I do work with NRG, the legacy group for RTOG, and there are very big advocates to doing bladder preservation using modern techniques. Lastly, just to wrap up before we hit the end of the hour here is fluorescent or blue light cystoscopy. Hexaminolevulonic acid, or 5-ALA as it's known, was actually approved in Europe way back in 2004. And the product in European countries is known as Hexvix. I was fortunate to participate in a lot of the early trials in the early 2000s using the compound here in the United States known as SISU. And it's approved intravesically for the detection of non-muscle invasive bladder cancer. And the way it works is the 5-aminolevulonic acid is preferentially taken up by neoplastic or inflammatory cells. Now that's the rub. You really have to do a bit of intravesical therapy with SISU to be able to differentiate with your eye what's an inflammatory cell and what is in fact a tumor cell or carcinoma in situ. Of course, you're going to biopsy suspicious areas, but if you do this quite a bit, you're actually going to be able to decide, oh, that's an artifact or that's a blue light positive area that's not cancer, it's probably inflammatory. So what happens is the 5-ALA is taken up by hopefully the neoplastic cells. It's metabolized to a protoporphyrin, which under blue light fluoresces, and 360 to 450 nanometers. It fluoresces red and identifies neoplastic tissue. Here in the United States, the Hexvix, or excuse me, the SISU product has to be combined with the Storz D-Light blue light system. There are other blue light systems available outside the United States made by Wolf, but the one we have FDA approval here as a combination with the SISU in the United States is the Storz D-Light system. So here's an example, and this is the power of SISU. The power of SISU really is to pick up carcinoma in situ. Yes, it can pick up extrapapillary lesions, but they tend to be low grade. This to me is the magic bullet. We all know that carcinoma in situ is probably the scariest bladder cancer we have out there when it's non-muscle invasive, because it can become very muscle invasive and very metastatic without actually demonstrating much inside the bladder. So here is again one of the early studies that led to the approval, blue light versus white light. So the way SISU works is you put the drug in the bladder usually about an hour before the procedure with a catheter. The patient holds it in their bladder, and then you go to the operating room. You don't want it to be longer than 3 hours because then you start to lose the effectiveness. So the sweet time is usually about an hour to 2 hours after the installation. You go to the operating room, and then you do your normal white light examination, identifying any lesions that you see under standard white light, and then you flip on the blue light. And remember, the blue light system is not just the 350 nanometer blue light. It also has to do with the light cord and the lens system. So you can't just pump a blue light in through a regular cystoscope. It's got to be the whole system, the light cord, as well as the lens system in order to get the optimum observation of the blue light red fluorescence. So here you see there is an improved recurrence-free survival, mainly because it allows you to identify aggressive high-grade carcinoma in situ. And again, I think this is the biggest power of the blue light cystoscopy. And right now in the United States, it's pretty much indicated for anybody with newly diagnosed bladder cancer gets a blue light evaluation by us. If there's a lot of gross hematuria, very difficult to do blue light cystoscopy, but in patients with newly diagnosed bladder cancer, it's very effective at helping us not only identify carcinoma in situ, but in our academic teaching center, we use this for the initial TUR as well, because we will flip between the blue light and white light, and we can actually see the rim of tumor that's been resected either adequately or inadequately, and we'll go back and take more of a margin until it no longer fluoresces. And this has been really pioneered in Europe, and we've taken this up as well with our TURs to get a maximum TUR here in the United States. So we were fortunate enough, if anyone's interested, you can go to YouTube, and we have a very nice instructional video on blue light cystoscopy for the detection and treatment of non-muscle invasive bladder cancer. It is available on YouTube, and it's about a 7-minute video, and it goes over all the nuts and bolts of how to use SISU. So that comes to the end of my my formal comments. This is Thomas Jefferson University, and you can see the city of Philadelphia out here in the background. And I hope that many of you have a chance to visit here once the pandemic is over and see the history here in the United States. I've had the good fortune of actually not being in Panama, but having gone through the Panama Canal with my family several years later. And we've been to Costa Rica on several occasions, and we've been in your beautiful Central American countries, and it's a beautiful place to visit. And again, looking forward to when we're able to visit each other once again. So again, Angel, thank you very, very much. And Arturo, thank you to Philadelphia International Medicine for this wonderful opportunity.
No, thanks to you, Lenny, because it's been wonderful and very helpful presentation as well. Again, going to the housekeeping things is to my colleagues down here, if there is any questions or comments you would like to make to Dr. Gomela, please use the chat system that it's open in there. In the meantime, just a comment, and I guess you agree with me, you know, whenever we speak about non-muscular invasive bladder cancer, we're speaking about 3 diseases, not one, because the TA, T1, or CIS, the behavior and the way we approach them is different, you know. And speaking also about the blue light, your last comment, there is a piece of equipment from Olympus as well that I don't know if you're being exposed to. It's a narrow band imaging that seems to mimic this, and it's well for those who does not have the blue light, the SISU, etc. It's you know, something that could help. But again, yeah, you were.
Yeah,
gonna say
we
something.
actually we had advanced the Olympics narrowband imaging system here. And again, I think perhaps the fact that I was raised on the SISU and the hexvigs that gave you a clear target. Myself personally, the narrowband imaging never really helped me identify. We did have it for about a year and a half. Now, again, it could be that I'm biased because, again, my experience with the hexvigs and SISU now goes back 15 or 16 years. So I'm very accustomed to it. Again, I'm not saying it's not worthy. It certainly has its utility. I think in particular for upper tract tumors, right now, I think the narrowband imaging, we don't have anything good for upper tract at this point, but I think the narrowband imaging, what I've seen from my colleagues when he was working, Dr. Bagley, way back when, did a pretty good job of upper tract identification with narrowband imaging. For me, in my experience in the bladder, I don't find it too useful.
Thank you. Any comments, any questions, or I know we're getting close to the time.
There is a question there from Dr. Carlos Garcia.
Yes.
In the chat.
Okay.
Yeah, so there's a question here from Dr. Garcia about the
Yes.
docetaxel and the gemcitabine. So yes, the data does show it does treat carcinoma in situ. Many of their patients, though, that are going to be reported in the paper that's going to be coming out in Journal of Urology any day now, most of those patients had papillary disease with some CIS, which is very different than the Adteladrin trial, where we had a high predominance of carcinoma in situ in almost 70% of the patients. But again, I think there's anything you can do to benefit your patient. Again, remember that the docetaxel gemcitabine trial was not a prospective randomized trial. It was a retrospective analysis of several hundred patients at many different centers around the United States. And it has to be viewed as such. But again, monotherapy, not so good. Combined chemotherapy perhaps is more beneficial.
Yes. Lenny, how do you approach your patients? Still being BCG the standard of care now, determined patient arrives to Jefferson to be seen by you. And I know that probably you do have BCG still. We are running very short or almost nothing here. And we're in the time of mitomycin and gemcitabine, etc. And Pembro is a dream still for us. But how do you approach the patient?
So we do explain to the patients the shortage. Most of our patients have already been on the internet before they come to see us. So we follow the AUA SUO guidelines. If you've got high risk bladder cancer, non-muscle invasive bladder cancer, we will treat you with half dose induction for 6 weeks. And then we will go with 1/3 dose maintenance. If you don't have a response after that first half dose 6-week induction, we will do our best to try to give you a full dose induction if we have it. Again, the problem is we do a weekly assessment of our inventory. We have a company known here as McKesson that keeps us supplied with BCG, and it varies from week to week. We do try to hold some back in reserve for those high-risk patients who come in. So high risk get at least a half a dose. Maintenance, they get a 1/3 dose. And for lower intermediate risk disease, we do try to use intravesical therapy. Gemcitabine is normally what we'll do, or mitomycin, but I will tell you based on this latest data, maybe we will start using the combination of docetaxel and gemcitabine. For low risk bladder cancer, absolutely no reason to use it other than follow the patient with periodic cystoscopy and ablation.
Dr. Alvaro, you're on mute.
Yeah, if there's no more comments, I simply wanted to say some few words, as summarizing what we've had here, and as non-muscle invasive bladder cancer remains a very challenging disease, and then the rate of recurrence and progression, it's really pretty high, and we lately have had several new developments. However, the high recurrence rate and progression rate, we need to develop more definite therapies and also consider major procedures in order to inhibit the progression of the disease. It is of paramount importance to take decision in order to prevent the progression of the disease, and that will determine the difference between quality of life, and ultimately death of these patients. And non-muscular invasive is where the majority of the patients come to us. So the decision that we'll take, we should offer them the best option, will keep them away from the nightmare of progression and recurrence and muscular invasive bladder cancer. So I will thank Dr. Gomela for this extraordinary participation and for having us with his time on his and next time will be hopefully in Panama, so we can see in person each other. Thank you, Arturo, as well, for your sponsoring, and stay safe. We'll see you in a couple of weeks with another interesting topic. We will have a group of pediatric urologists speaking with us, and the participation of Dr. Celeste Alston from Panama, Dr. Figueroa, and other doctors from
Dr. Bani Hani from Nemours Children's Hospital, Alfred E. DuPont.
Thank you.
Thank you, Dr. Gomela. Thank you, everybody, for connecting today. It's been an honor to have a panel with you. Have a good one.
Thank you. Can you, Arturo, I want to take a picture. Can you flip us back to the our bigger video screen?
Yes, sir. 1 second. I'm going to stop sharing the.
Oh, excellent. Excellent, excellent. Superb. Thank you.
I'll send you one too. Please smile. There you go. 1, 2, and 3. Awesome. Thank you, doctor.
Thank you. Now, Angel, thank you so much. I hope it filled the bill. Say hi to everybody.
Absolutely. I have given to you my cell phone number as well, in case you